This is the Etiology Podcast. I am your host, Alka Kubaku, licensed social worker and psychotherapist. In this podcast, we explore divisive issues around food, health, and body image with the goal of mending relationships within the eating disorder recovery professional community and creating a space where a multiplicity of perspectives can coexist harmoniously. This podcast is uncensored and encompasses the political and ideological spectrum. If you believe something you hear is harmful or misinformed, please be respectful to the speaker. And also, feel free to reach out about recording another episode on the same topic from your vantage point. My hope is that if, as professionals, we can hold each other's stories with respect and compassion, we'll be better able to do so for our clients. So much of Western medicine has been tied up with body weight. Weight is often disproportionately and inaccurately associated with health. Weight loss is a common recommendation for many health conditions. Although eating disorder treatment typically emphasizes body acceptance and destigmatizing weight or weight gain, weight remains central to so many aspects of the treatment process. Body mass index, which is a measure of weight in relation to height, is used to diagnose, is this anorexia or atypical anorexia? It's used to monitor recovery progress. We might ask, is this person weight restored? And it is used to determine what level of care is needed and when a person is ready to reintroduce physical activity. Taking a person's weight is so easy. It's clear, it's objective, and it requires only that they step on a scale, all of which makes it an appealing assessment measure. However, like most shortcuts, it carries the risk of promoting inaccurate conclusions about the individual and perpetuating harmful stereotypes and biases. In this episode, Catherine Williams, PsyD, discusses decentralizing weight as a marker of health and recovery. She shares her experience teaching health at every size and eating disorder awareness to medical students and touches on alternative physical and psychological markers that can provide more accurate, weight-neutral indicators of someone's eating disorder status and recovery progress. Catherine is a licensed clinical psychologist and graduated with a doctoral degree from Massachusetts School of Professional Psychology in 2014. Catherine completed her postdoctoral fellowship at the Cambridge Eating Disorder Center and has expertise in the treatment of eating disorders, substance use disorders, and borderline personality disorders. Prior to joining the Department of Psychiatry and Behavioral Sciences at UMass Medical School in 2022, Catherine provided individual and couples therapy and served as the clinical director of 2 outpatient mental health clinics. She has provided clinical supervision and didactic seminars for pre-doctoral trainees, postdoctoral fellows, and psychiatry residents. Hi, Catherine. Thanks for coming on today.
Yeah, thank you for having me. It's nice to see/hear you.
Can you start by just telling me a little bit about what you do in the eating disorder recovery field?
Sure, yeah. I have like a kind of a unique but really cool position. So I'm a psychologist, and my current position is I work in student counseling services at UMass Medical School. So I see enrolled students, so med students, nursing students, and then we also have PhD students. So I see them for therapy, both with and without eating disorder diagnoses. And then I also get to supervise psychiatry residents and teach psychiatry residents specific techniques for eating disorder treatment. And on top of that, I also get to do some fun research. I'm working right now on a project with a OB who's associated with UMass, and we are developing a health at every size intervention specifically for pregnant women, combining health at every size components with DBT and mindfulness to really help them navigate just the minefield of body image and body image issues that can arise during pregnancy and after.
That's very cool. This wasn't our topic today, but sort of ties in when you're talking about teaching psychiatry resident students
Mhm.
about eating disorders and working. Something that I'm encountering now, actually with working with clients, is the divide between health at every size and medical field, especially and it's something that's been on my mind because it feels so tricky when somebody's getting conflicting medical advice from two different providers.
Yes. And actually, even more so, and this is something that like I've become much more aware of in my current role, is I have med students who are in different stages of recovery from eating disorders. And unfortunately, even though we know that weight as a indicator of health is not evidence-based, a lot of their curriculum is still very much aligned that way and is promoting, you know, weight stigmatizing and just plain untrue information. And so they're like, okay, I'm learning how to be a doctor and they're telling me this, and this is like an important thing. And it goes against everything that I'm hearing in recovery. And oh, it's interesting because a lot of them they'll email me after certain lectures and they'll screen grab shots and be like, "Can you believe that they're saying this? Like, tell like this is not okay, right?" Um, and it's not okay. And at the same time, I think it's really hard. It's really hard for people to let go of, quote, the way things have always been done, and also things that are hard or important. And this is one of those things. And I did just a brief poster presentation talking about the impact of weight stigma just generally on people receiving medical care um, at just a UMass event a couple of years back, and I was kind of anticipating that I was probably going to get like a lot of eye rolls. I was really pleasantly surprised when um, lots of folks, including, and I have to preface this by saying, like, I try not to stereotype. And when I saw like 3 or 4 older white uh, cisgender male appearing physicians coming to me, I was like, all right, steel yourself. It's going to be bad. But all of them were like, we had no idea. Tell us more. How can we like, and so I was really encouraged by that. But it's also, I think it's interesting too, because the flip side, right, is that, you know, we have to have a metric, or insurance wants us to have a metric by which we measure, so-called progress or recovery. And
Yeah.
how do we balance that need with our value of decentralizing weight as a marker of health?
Yeah, so there's that piece, and then the one that I've encountered as well, and I'm curious when you're interacting with medical providers, and especially ones who are receptive, sort of how you've seen this navigated, but when I have, let's say, clients who are confronting more severe physical illness, and those illness, like that particular type of illness, is correlated with weight. So, doctor is just like, "Okay, these are the statistics," and I know there's always this correlation. Correlation is not necessarily causation and all of that, but it seems that the simplest marker that people have for progress, and the simplest marker that people have for sometimes showing correlations between this and recovery, is weight.
Mhm.
And yeah, how have you seen medical providers and psychiatry students navigate that information?
So they're interested, they're very hungry for it. When I explain,
Mhm.
I do an entire lecture in the series. I start by just talking about weight stigma and basically like bringing them into the conversation and saying, like, this is something that it's impacting all of us. It doesn't mean you're a bad person. It just means that,
Yeah.
you grew up in the same culture that we have all grown up in. And they're like, oh my gosh, this, like, I had no idea, and it makes sense, and I want to do better, which makes me feel really good.
Yeah.
Uh, it's interesting though. I've noticed a shift in the field, and now that I've said that out loud, it makes me feel really old. Maybe I am. I don't know. That's for maybe another time. But um, when have this memory when I was doing my postdoc fellowship, I was working in inpatient eating disorder treatment, specifically with adolescents and young adults.
Mhm.
And one of the questions that someone in my postdoc cohort had when we were first getting it, started was, how do we respond to people who say that they're afraid that treatment is going to, make them fat? And what we
Mhm.
were told to say was something to the effect of, we would never let that happen because that would be not healthy and bad. And our goal is to make you
Mhm.
healthy. And all of us are like, okay, yes, that's what we'll say. And I feel so, I want to say guilty because I do feel guilty because it goes against my current goals and values. And I also try to give myself some compassion and grace because at the time I really wasn't aware of the damage that that was doing. So yeah,
Yeah.
that's what we said. And we didn't think twice about it. And it wasn't until, you know, I was done with my postdoc, I was in private practice that I started to hear about health at every size and really start to question like, hey, what are we doing here? And I think something that really motivates me to do this work and to, specifically educate the educators, our future physicians, um, is my desire to change that context for people.
Yeah, that'll be such a game changer. Just having medical providers who understand eating disorders. And I've seen people without history of eating disorders who have received, let's say, weight loss recommendations or dietary modifications and maybe followed through on them and had positive results from them, and it's been fine. But I've also seen, like, in the eating disorder recovery field, just we need more understanding of what those recommendations do to people, especially people who have vulnerabilities.
Yeah, and even I think even if the person who's receiving, if a doctor says to a person, "Oh, you know, you need to lose X amount of pounds, or you need to try to do this to make that happen," even if they don't develop an eating disorder, it's reinforcing this notion that it's positive and good and moral to make yourself smaller,
Mhm.
and that that we have this personal responsibility to make ourselves to change our bodies um in by doing things to it that we know not to be in their
Mhm.
best interest.
Yeah.
And I think and also there is, the devil on my shoulder saying, well, there are people who, you know, are so overweight that, and I don't love that term, but I can't think of really another one right now to sub for it. So feel free to like just
Yeah.
scratch it out. But people who, because of their weight, are not able, to move around or access their daily life in the way that they'd want to. And yes, I agree that that's not a quality of life. And I understand that, like, well, part of what's going to have to change maybe for these people is losing some weight. But I want to hold that alongside, right? And I'm a DVT gal, so I'm all about dialectics. It's probably the only way I've gotten this far in my career. But I want to
Mhm.
hold that. I want to hold that, and I also want to hold like the harm that happens when people are prescribed GLP-1s or told to go on certain, diets or change certain things with because their BMI has gone over a certain number. I
Yep.
actually have a colleague who she is about 9 months pregnant, and she knows that eating disorders are my thing. And she came in, she's like, "You are going to be so mad." And I was like, "Oh my god, what happened?" She's like, "I went to my PCP." She was about 6 months pregnant at the time, so visibly like and like very like
Mhm.
clearly pregnant. And her PCP said, "You gained a lot of weight. What do
What?
you what do you think about Ozempic?"
What?
She's 6 months. She was like, "I had to tell you because like I was so blown away." And I was like, "Oh my God." And she was like, "And
That's so
I don't have
dumb.
an eating disorder." And I was really like upset by that. And I like that's the culture that we're in right now in medicine. It's an uphill battle, which is why I think it's even more important to be, getting in on the ground floor and in
Yeah.
educating people who are going to be physicians. And there's a really wonderful group. I don't know if you're aware of Medical Students for Size Inclusivity, MSSI.
That's awesome. I haven't heard of it.
So they're fantastic. Huge plug to them. I am on their board of faculty advisors, and it's been a huge pleasure. They are basically a grassroots group of medical students from all over the country who are working to advocate for and incorporate health at every size into medical school curriculum. And they're doing wonderful, wonderful things. I cannot say enough great things about them. But the reason that I think it's such a great group is that they are in school and they're recognizing this isn't okay. And not necessarily because they themselves have had eating disorders, but because they know people and they're saying, like, we have to do something about that. And they're not, and from a hierarchy perspective, a med student really has absolutely no power. And so for them to go out on a limb like this is really brave, and I think it's really exciting. It gives me hope.
Yeah, and it's also amazing because they aren't, like, high up on the hierarchy now, but they will be.
They will be, exactly.
Um, what was I what have you seen we can just keep this as a topic and we'll move with wherever it takes us. I know
Yeah.
it's a little different from what we had originally talked about, but what have you seen it be replaced by? The specifically when weight loss recommendations are given in response to, uh, an actual health condition, what have you seen those recommendations replaced by in terms of what doctors will give clients to walk away with?
So I don't know that I've seen or heard. I think I know what what I would like to see in here is, thinking about things like what are your goals, right? Well, my goal is that I want to be able to, my 6-year-old has a fun run and I want to run a half mile with them for their fun run. Okay, great. So how are we going to get you from where you are right now to that? If you've never run before and you're not active, we're going to have to make a plan and we'll take steps. And increasing physical activity is, I mean, I'm not a physician, but my understanding is that it's pretty beneficial for most people, barring illness or injury. So great. So if this person is now moving and now maybe their resting heart rate is getting into a more normal range, right? And their blood pressure is normalizing without medication. Those are what I would consider, and again, I am not a physician. I don't want
Yeah.
to be clear about that, but those are objective measures of health,
Mhm. Yeah.
right? Um, you know, weight tells us it's a measure, it's gravity, right? It gives us no information other than the pull of gravity on your body.
Yeah.
It doesn't tell us about anything about how our body is functioning actively right now, where we have so many pieces of information available easily to us, like blood pressure, heart rate. You can do a lab panel or an easy lab panel and look at someone's, overall, you know, their lipids and their organ functioning. Let's use those things. And maybe
Yes.
and for some people, maybe that's going to mean that they need to change certain parts of the way that they eat. Um, okay. But let's not say that success is going to be defined as this person losing weight, because that's very short-sighted to me.
Yeah. That clears up one of the primary misconceptions that I hear around health at every size, which is that we're just discarding the impact of lifestyle on a
Yeah,
person.
or that we're saying that you know, it it's healthy to be, however, whatever, any weight. And it's like, well, no, we're actually not saying that. What we're saying is that people, and I don't speak on behalf, I'm a student of health at every size. I might be butchering this, and if I am, I hope someone will call me out immediately. But my understanding is that what we're saying is the right to healthcare that is respectful and competent and accessible and evidence-based is one that people deserve regardless of what their size is.
Yeah. And also de-emphasizing when you're talking about I hear you saying 2 things. One, in terms of alternative, what are we focusing on if we're not focusing on weight? One is movement toward instead of away.
Mhm. Mhm.
And that movement toward will be different for the individual depending on what they're encountering. What are your goals and how do we move toward that? And that might include aspects of exercise and perhaps dietary modification in ways that are safe and in line with the specific person and their body's needs.
Absolutely.
And then the other piece is when we are looking at tangible objective health measures, there's a lot beyond weight.
Absolutely. And it's interesting, like, something that I often find myself saying is, like, you cannot tell by looking at someone unless they're, like, blue in the face, then you have an idea that maybe perhaps they're not getting sufficient oxygen, but, unless they have, like, an obvious gunshot wound or they're, not breathing, you can't really tell someone's health by looking at them.
Yeah.
And that is what we do. It's crazy to me, right? Like, we have MRIs, we have X-rays, we have CAT scans, we have, like, ultrasounds, all kinds of cool stuff. We can poke around, we can see what's really going on. Like,
Yeah.
we don't need to, be lazy and just look at a person, right? Like, that's not good science. And
Yeah.
I think that for me, it's funny. It goes, and I want to, like, also name my own privilege in that I am a white cisgender educated straight sized person. Um but I was talking with some colleagues about, like, how did you become, like, why is this so important to you? And I was really thinking about it. And I think it really takes goes back to an experience that I had as a kid. I had a brain tumor, and I was completely asymptomatic. They found it completely by a very, very, very lucky like, chance. But I didn't look like a person who was sick because, like, I I was looking normal. And people around me, kids, even teachers, would say things like, "Oh, you're just trying to get out of this," or "You're not really sick. Like, why are you so worried?" And I didn't really put it together. And then you can't tell by looking at but you look fine to us, right? Like,
Yeah.
their idea of somebody with cancer was maybe looking with, no hair, but I didn't have chemo. Um, and even like, and I was really fortunate that my surgeries were done in such a way that I was able to, get back to school and my activities pretty quickly.
Yeah.
And there was this, like, oh, well, I kept getting this message that you're not really sick, which was really scary because, like, I thought and I knew that I was, and then it kind of made me, like, not trust myself. And that's something that I think translates here, right? People who live in larger bodies are constantly getting messages that they can't be that they don't know what's best for them, or that they can't possibly have any insight into how, what's wrong with them or what's good for them. And that's just really dehumanizing.
Yeah. You don't know what's wrong with you or what's good for you. And the fact that you're ill or you're struggling with something is linked to the shape of your body.
Yes, exactly. And this idea that there's also a moral piece, right? So, you know, well, we have this moral obligation to starve our bodies so that they fit this very narrow and genetically unrealistic standard. Like, what? Like, when did this become a moral issue? And I think it definitely is.
There's so much that has gotten tied into it. So even when somebody is coming from what they see as a very intellectual medical perhaps scientific viewpoint and are just like, hey, correlation, weight
Yeah,
and
but we can do better than that, right? Like,
whatever. There's so much that is tied into that beyond what they might be intending or hoping to communicate.
yeah, absolutely. And as a eating disorder treatment provider, I've been really trying to intentionally incorporate this with my patients who are recovering from any number of different eating disorders. And it's interesting because, again, the training that I received for people who had restrictive eating disorders and had lost weight, and part of what was determined was that they needed to, regain some or all of that weight in order for their body to be working healthfully. It's I bump up against that sometimes because, as I think most people with eating disorder experiences know, it's not always just easy to lose or gain weight. And if I have a patient, there was a time where if I had a patient who says to me that they're eating everything on the meal plan, they're not over exercising, and I'm seeing their weight not increasing or even going down, then, oh, well, that tells me that maybe they're not being transparent with me. Or maybe they are being transparent and the body is really complicated and it's doing what it's doing. And let's decentralize weight. If they're telling me that they're eating, if their labs look good, they're feeling they've got energy, maybe we de-emphasize weight and say, like, keep doing what you're doing.
Yeah.
Right? If your periods come back, if you're a cisgender female and your period comes back at a weight that's lower than what we would expect it, then maybe we can be flexible on both ends. And I know
Hmm.
this is controversial too, because weight restoration, especially for kids with eating disorders, is something that historically has been seen as, a really important component for many reasons, but specifically for women, for cisgender females, in terms of like bone health and endocrine health. And I'm
Hmm.
not trying to say that we should not encourage kids to weight restore or anyone to weight restore, but just again, this idea that there's only one ultimate measure of recovery or success, I think is really short-sighted, and I think we can do better.
Yeah. That's a really interesting and also feels like really sticky topic. I've definitely
Mhm.
seen that as well. And firstly, tell me a little bit about how or if you've seen that done successfully. So decentralizing weight in eating disorder treatment, particularly with restrictive eating disorders, and restrictive eating disorders where there's high level of ambivalence around recovery.
I have to say, I haven't seen it I haven't seen it at a very an acute level. I mean, I see patients who are stable enough to be seen, on a weekly outpatient basis. So most of them are not in an acute place medically. So I do have that luxury. But I think it happens. I work with a lot of I know a lot of athletes, um, and you know this idea that like part of your eating disorder is that it's hijacked your love of your sport, whatever that is. And maybe recovery can still allow you to enjoy it, right? Maybe we can reverse that. The idea that recovery means that you're not doing that thing because that thing was associated with or contributing to your eating disorder, or that you can't do that thing again until you reach X weight. To me, it just feels it feels like it lacks a lot of nuance.
Yeah. So there's the piece of we can't judge whether somebody's recovered by looking at their weight alone. We need to be
Mhm.
looking more holistically at other measures. And
Absolutely.
and there's also that when something that is legitimately tied into a person's sense of purpose or their joy in life and their hobbies and talents becomes tied to their eating disorder, we can hold that vision and that goal and start working toward bringing it
Yeah,
back. Of course, when it's safe too.
absolutely.
Yeah. There's so much here I want to unpack. Um, Tell me a little bit about some of the key experiences that brought this to your attention that make you, even as you're talking, I can hear that you're really passionate about it and
Yeah.
make you want to
I
do something.
think I think working at all different levels of care throughout my training and seeing how difficult it is for anyone of any size to recover in the current culture that we live in. It's really heartbreaking, right?
Yeah,
You have people who are working so hard and really just fighting something that most of us could never imagine. And then they have to go out into a world that reinforces it.
yeah,
I had a patient who had, as many do, struggled not only with an eating disorder, but also with substance use many years back. And well, at the time that I was working with her, was in pretty solid, sustained recovery from her drug of choice, which was heroin. Um, and she said to me, I thought the hardest thing I would ever have to do was, was stop using heroin. And it wasn't easy. It was really hard. But once I detoxed and I, made the changes I needed to make in my life and it wasn't around me as much, it, it became easier to sustain. But I can't do that with my eating disorder because it doesn't matter if I sit all day in a partial program and I eat my meals there and I do the worksheets, but the second I leave, I go home and there's weight loss commercials and my roommate's on a diet and my mom calls and tells me about her diet. And it's like, that's a really good point. Like you can't escape food.
you can't escape food and you can't escape messages around food and
Right.
around weight loss. When you're having medical students coming to you with an eating disorder, I imagine you've encountered um, students who you're introducing them, let's say, to health at every size or intuitive
Mhm.
eating, and they're coming in with so many messages in opposition to that from medical training, and messages in opposition to that that are not just like, this is what I was taught as a kid, but this is what I'm being taught now as I'm
Oh
pursuing
yeah.
something that's really important to me. Tell me about the process of navigating that and what that looks like for you.
It's interesting because most of the patients that come in are very much open and aligned with health at every size and the ideas of you know decentralizing weight as a marker of health, for everyone except themselves,
Okay.
which I think is not exclusive to medical students, right? I think people who
Mhm.
struggle with eating disorders can be people who genuinely, really hold weight inclusivity as a value,
Yeah.
right? And that can also, it's really interesting. There's a lot of, I think, cognitive, just dissonance that I see people sitting with, right? Like, I mean,
Yeah.
I've had patients who have been very clear, like, I know that all of this is wrong and harmful, and I would never encourage it or say it to anyone else.
Yep.
And I can't give myself that compassion. I can't give it to myself.
Yeah. So even in the medical field, what you're saying with people who are struggling with eating disorders is more similar to what we tend to see just with anyone, that there's a dissonance between my value system and the way I treat
Mhm,
myself,
mhm.
rather than there's a dissonance between what you're telling me and what my professors are telling me, or what, yeah.
Both, yeah. And I think also it's interesting too because we can't we need to also really name the impact of weight stigma, weight bias, just in general in professional things, but especially in healthcare, right? Their studies have shown that healthcare providers of many different credentials types who live in larger bodies report that they are, taken less seriously by patients and by colleagues.
Yeah.
So, right, like this is, and we have to name and hold that. We can't just be like, oh no, that doesn't happen because we know that, how smart you are has nothing to do with your body shape. We do know that. And that's
Hmm.
not the world that we're living in.
Yeah.
And as a therapist, that's something that's really hard and hard and again hard and important for me to sit with.
Yeah. When you earlier on, you had mentioned wanting to name your own privilege, or like that I haven't had the struggles um in that way, just or like being judged for my body in that way. Was the goal in line with what you're saying now to acknowledge that there are people who struggle with this really deeply, even as I'm talking about working towards shifting it. We don't need to gaslight or to minimize how difficult it is.
Absolutely. And also and I think also I I want to name and be aware of cognizant of my privilege because I think in social justice, this is, I think, really a difficult dynamic that, but a very common one, where people are coming in to try to help and are kind of imposing their ideas, their thoughts, their experiences, their values on people who are, really suffering more acutely in that moment without creating space for the expertise of their lived experience,
Yeah.
right? Like I know, and I feel so sad and regretful about this, but I know that I have sat with patients who, for lots of different reasons, um, have learned that it's not okay for them to be the size of their body that it is when they are being, healthy. And, you know, I've said, like, well, well, it doesn't matter what other people think. Well, that's easy for me to say. Again, I am a straight size cisgender white woman.
Yeah.
And so
Atypical.
I want to hold, like, it's not easy. And I also, you know, I want to give space for people to incorporate their lived experience and to support them and lift them up.
Yeah. Incorporate lived experience and have space for the depth of their suffering without you as a provider needing to come in and make it better or make it change in some way. Though
Yeah,
we are,
just holding space for the discomfort. And I mean, I I myself am a parent, and I've worked with parents, and I think one of the most important, but also most challenging parts of being a parent, right, is being able to sit with your kids' distress without rushing in. Um, Brene Brown says, don't steal their struggle. And there are times where it's really hard not to because you see them, you know, getting picked on by their friends, or they really, 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 really want to have a later bedtime. And you know that this is going to be disaster for them and everyone in a 10-mile radius of that. Right.
Yeah.
And it would be easy to just say, okay, right. Or to swoop in and fix it. And that's not how we learn. It's not how we grow.
Yeah. And there is a humility also in the face of the enormity of another person's pain
Mhm.
in saying, I haven't been through what you have, and I don't have a one line slogan that will make you feel better.
No, but I'm here with you.
I'm here with you. Yeah.
It's, um, people ask me like, you know, like, what made you like, what really has informed and shaped who you are as a therapist? And I, um, I think back to actually my mom. Um, and so as I mentioned, I had brain tumor when I was a kid. And if you've ever had an MRI, you know that it's like loud and not fun. So imagine this, you've just had brain surgery and they're like, let's go in an MRI and it's going to be loud. And as you can imagine, I was not super amenable to this. And to back up, after I had um, I had had two surgeries, and after my first surgery, they had done that, and I was like, never doing that again. When I found out I had to have a second surgery because we had metastasized,
Mm.
um, I said, okay. And again, I'm 11 years old, like negotiating with neurosurgeons. So I said, okay, but promise me you won't make me do an MRI post-op. Promise, promise. And I don't know what they said, but the message that I took home was, we promise. I'm pretty sure that's not what was said, but that's what I heard. But anyway, so I'm post-op and they're like, okay, we're going to put you in the MRI. And I'm like, oh, no, no, no. No, we had a deal. And they're like, we have to know, we have to see, and we have to make sure we didn't miss anything. And there's no other effective way for us to do it. So my mom's in there with me. And I'm like looking at her like, hey, mom, tell them no, tell them they can't do this. And my mom, God bless her, doesn't tell them they can't do it, but she says to them, can I go in with her? And so they're like, yeah. So my mom lays down on the MRI machine and we go in together. And that's what I try to do as a therapist, right? I don't want to say, like, no, I don't want to jump in and say, you don't have to go through something that is really important, even though it's difficult. And I'm not going to say, like, oh, I know it's hard, but you'll be okay. And I'm over here outside and you're in there, but hey, you're okay, right? I'll go in with you.
Wow, that's such a beautiful story. She was able to go in the MRI with you, like not just in the room, but in the.
No, yeah, she was on the table with me. It was, I mean,
Wow.
I can't imagine that it was comfortable for her, but and it didn't make it any less painful for me. Um, but it made me able to go in.
Yeah. I want to rewind to a couple of big statements that you made earlier. So, when you're talking about A, not judging whether a person is ready for, let's say, lower levels of care, or B, when a person is ready to resume a sport,
Mhm.
the question that I'm encountering and that I can see a lot of people listening to this having is eating disorders can be deceptive,
Oh, for sure.
and they can be deceptive in the way that people communicate about them and also in the way that people experience them within themselves.
Absolutely.
So weight is an easy and imperfect measure.
Mhm.
And That's where it feels like there is a tricky space where when somebody's coming in and saying, I'm doing everything you're telling me to, and perhaps the answer to this is in the other physiological measures that you're talking about, but tell me about how you've seen that navigated or what
Well,
if
well,
somebody,
I think, as therapists, the therapeutic relationship is the be all end all. And it's really hard for a person to feel safe and held in a relationship if you're basically saying to them, I don't think you're being truthful. So going into it with curiosity, hey, you're telling me that you're doing everything, you know, we're seeing this data. It's not adding up. There must be other things going on. So let's look at it.
yeah.
And
No,
like let's be curious.
mhm. Yeah,
And for some people it could be like, oh, well, you're saying you're eating everything. But I see that that you have to part of your meal plan is, a caloric bev at every meal. Oh, well, I guess I haven't been doing that. Okay. Now, maybe a caloric bev at every meal isn't going to make a huge world of difference, but the way that we find it and address it is much more effective.
yeah. So there's an acknowledgement there that maybe what somebody's telling me might be
Hmm.
fine with what actually is happening, but the way that we're addressing it is without assumption.
Hmm.
And
And without judgment, like you're doing the best you can. I believe you when you say that, when you tell me I am eating everything, I can't. I absolutely believe you.
yeah, and what you're doing instead is sharing the discrepancy that you're seeing with them
Mhm.
and allowing them to explain it to you. And I've seen this as
Yeah.
well. I've had clients where we've had that, like, I'm doing everything, but we're seeing, let's say, weight go down. And when I brought it into them, they might say something like, and this was when I was in higher levels of care, I was just really scared about getting stuck here longer. And maybe I didn't share fully what was happening with you because of that, or I was carrying
Oh,
around it.
absolutely.
But it's coming from them rather than a judgment.
Right. Right. And it's coming from them, and it's not me saying this must be what is happening for you.
Yeah.
And haha, like I've solved the mystery. Like, no.
Mhm.
And
Yeah.
I think and my experience is that when I have taken kind of that approach, patients who patients who otherwise may have just kind of distanced themselves from any kind of care will stay engaged.
Yeah.
And I think I'm a big proponent of harm reduction, and I think something is better than nothing. And of course, I would never encourage someone to practice in a way that would endanger themselves legally or their clients, obviously physically. And I'm really transparent with my patients that, if you're not ready to access a higher level of care, here are the the bottom lines for me, right? I need you to be getting labs weekly. I need I need I need to know that you're medically stable. When if and when that changes, I can't ethically continue to see you without mandating higher, or having you go to a higher level of treatment.
Yeah.
And for a lot of folks, I mean, they'll do that for 5, 6 months. But then when it starts to dip, then at that point they are ready,
Yeah.
right? But if I had come in at the beginning, guns blazing, saying, you need a higher level of care, I can't work with you until you have done X, Y, and Z, they're just going to be like, no. And not just no to you, me, Dr. Williams, but no to treatment. And I would never want that to be someone's takeaway.
Yeah. I've seen that as well. And I feel like when we get into some of the controversy around harm reduction or managing risk, a lot of our bottom lines on both sides tend to be closer together than we realize.
Absolutely. Yes.
And it's just the language we use and the way that we approach it that
Mhm.
differs. So we all care about managing risk and safety, regardless of where we fall on these questions.
Absolutely. Yes.
Um, when you're talking about decentralizing weight in this, let's say, higher level of care equation, can you, and you've touched on this already, but can you name what measures you are centralizing when you have, like, let's say, somebody who needs to get their labs done every
So,
week
I
and they're,
mean,
yeah.
so looking to see that, that their labs are normalizing, ideally, if it's somebody who previously had a regular menstrual cycle, we would want to see, that return. Um, Also, there is a certain amount, I think, of cognitive flexibility that we see return at a certain base nutrition or base weight restoration, and
Mhm.
that I think it's not something that you can really measure tangibly, but in my experience, is like it's very noticeable.
Noticeable. Can you describe some of the indications on either side when it's not there and when you start to hit a point where you're thinking maybe something more is needed and when it is there and you're like, something has shifted?
Yeah, well, I think just the lack of rigidity, right? And I think it's easy to mistake the symptom, the eating disorder symptom of avoidance and rigidity for a lack of information. And the fact is that the majority of people with eating disorders are very well educated. And if they've had any previous interaction with healthcare and treatment, they're fully aware of the risks of their eating disorder. And it's not that they need to hear once again the damage that they're doing. What what they need to hear is that it doesn't have to be this way. And and joining there. And it can be something, the shift when I see it on my end could be something like, um, last time my nutritionist increased my meal plan, I had a complete meltdown, and it was days of coming back. And this time, like, I kind of expected it. And I won't say I was excited or happy, but I was able to go and eat my snack afterwards.
Yeah, that makes a lot of sense to me. It doesn't feel as all encompassing and like it'll swallow you whole. It feels like this is,
Right.
but I can handle it. I can handle these,
Yeah.
I can handle changes in the way I'm eating.
Yeah, I can see that there is another side. And I know that I'm not there, but I can see that side in a way that maybe I couldn't before.
Yeah. Will you ever on the reverse side, if you have somebody where, let's say, it feels like it's getting stuck at that really rigid, really difficult space, um, would that be an indication for you more support, or have you ever seen it go the other way?
Go the other way, and like needing a higher level of care.
Needing a higher level of care and specifically, like, because we're talking about decentralizing weight in the process
Mhm.
of assessing that, the rigidity and just overwhelm around it being an indication of that.
Oh, absolutely. And I think again, it's something that we can't necessarily measure, you know, with any kind of, test, but I think it's something that eating disorder providers just by virtue of experience, it's something that they can see, and it's very tangible for them. And it's something that I think that when I collaborate with other providers, whether they're psychologists or psychiatrists or PCPs, that we it's like you know what you're talking about. And it's a really interesting phenomenon. Thank you for listening to me ramble.
Thanks so much for coming on. Any last couple of words you want to wrap up with?
I think just like my hope is that more and more people can be more curious and more open.
Yeah. Thanks so much, Catherine.
Oh, you're really welcome. Thank you.